Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Rheumatoid arthritis is an autoimmune disorder in which the immune system attacks the lining of the joints, and it's different than osteoarthritis, where the joint cartilage breaks down from wear and tear. We'll hear all about diagnosis and treatment of rheumatoid arthritis from my guest, Dr. Christian Geier. He's an assistant professor of medicine at Upstate, specializing in rheumatology. Welcome to The Informed Patient, Dr. Geier.
Thank you very much. Thank you for the invitation.
What are the typical signs and symptoms of rheumatoid arthritis, or RA?
The single most informative sign or symptom for RA would really be signs of inflammation. So what a patient would typically report with rheumatoid arthritis would be a sensation of stiffness, and the stiffness would be typically something that occurs with rest. That's really a big thing to distinguish from osteoarthritis, like you said. The inflammation really leads to kind of a thickening of the joint fluid, and joints can become very stiff, tender, swollen in certain typical distributions. How that really reflects in daily life for patients can be problems with dexterity. So people may have difficulty opening jars, doing buttons, just activities of daily life. They may drop things more easily, and it also leads to pain. But it's not only pain, it's really an inflammatory pain, typically with stiffness, often in the hands, feet. It's really the main symptoms that gets patients to see a doctor.
And this being an autoimmune disorder, it can affect the entire body, right? Are there other symptoms beyond the joint pain and stiffness?
Yeah, so that's absolutely correct. One of the things with rheumatoid arthritis is that most visibly affects the joint. So that's what often is most obvious to the patient and the patient's physicians. But as you said, it really can affect the whole body, and it can affect lungs and heart as well. But that's usually not what brings a patient to see a doctor. So these would be more kind of chronic effects that people are monitored for, or they need to be treated separately. But that is absolutely things that are of importance for the long term. It is definitely not only a disease of the joint. As you said, it's a problem with the immune system and more with inflammation in general. So inflammation of the joints, but also can affect the heart, blood vessels, the lungs.
What are rheumatoid nodules?
Rheumatoid nodules are, as the name says, nodules. They're kind of tissue, similar to scar tissue and inflammatory cells that can form in some patients with long-standing rheumatoid arthritis, usually when it's untreated. Typical location would be sites of pressure, like on the elbows. Sometimes they can also develop inside the lungs. So that can then sometimes lead to some confusion and concern if someone has lung nodules on a screening CT scan, for example. But they are usually harmless. They often respond to treatment, and they can also get larger and smaller over time. So there can be sometimes an issue with these scans that they may enlarge, which raises additional concern, then sometimes leads to biopsies. So yeah, these are rheumatoid nodules. They are not overly common, but they can develop typically in patients who have had RA for a long time and that have had untreated RA.
Well, I want to ask you about diagnosis, but is this a condition that primary care providers generally diagnose and then refer people to someone like you for specialized care, or do you get involved in the diagnosis?
Both. So what usually would happen is that patients see their primary physician with certain joint complaints or concerns about their joints, and they get then referred to rheumatology, to me or some of my colleagues, for clarification. Often the first point of contact is the primary care provider, and they may order some of the blood work that can also help clarify that. That would be the typical thing. Sometimes people get referred to us for other concerns, and we end up incidentally diagnosing RA, or we find RA in an inpatient we get consulted on. But the typical pathway would be someone sees their primary care physician who has concerns about RA and refers them to us for confirmation, but also management.
How reliable are the blood tests for RA?
The blood tests themselves, they are very reliable in terms of that they are correct. So the lab tests themselves are very good. What may not be so reliable is the RA itself. People do not always follow the textbook. So because someone has a rheumatoid factor or what is called an anti-CCP antibody, so two typical blood tests that are positive with RA, doesn't automatically mean they have RA, or just because someone has these tests negative does not mean they don't have RA. So both can still happen, and both does happen. There are also some other tests that can give a sense whether a patient has untreated inflammation So these would be tests like SED rate and C-reactive protein. They are just measures of global inflammation in a patient, and they can also be useful to get a sense how active the disease is, but not every test works for every patient.
As a rheumatologist, can you tell by examining the joints just visually? Can you tell whether a person has RA or if it's osteoarthritis or something else?
Sometimes. For osteoarthritis, it's usually typical. It's really the distribution. For unknown reasons, there's usually certain distributions of the hands that osteoarthritis affects typically much more than rheumatoid arthritis. And sometimes the diagnosis is clear for RA on exam. That would also be usually in someone who's kind of longstanding with the right labs, because untreated RA really leads to certain characteristic deformities that can be seen on exam. What also can be seen on exam is if a patient has joint inflammation. That can also be typically felt when palpating, so pushing, pressing on the joints. That is also a big help because it helps distinguish between osteoarthritis and an inflammatory problem, which are treated separately. So it doesn't necessarily have to be RA, but it definitely could be. So it would be very suspicious for RA if someone has what we would term synovitis on exam, so inflammation of the joint lining. That raises the suspicion either for RA or a different inflammatory arthritis.
Now, how do you determine if the heart or lungs are involved?
There's a bit of controversy how closely to screen for that. It has been found when you look very, very closely in patients, you can find some involvement of heart and lungs in most patients, but that doesn't mean that it's really what we would call clinically significant. So for most patients, it does not really affect their lungs or heart too much, but it does over time increase the risk of having complications like heart attacks or other types of cardiovascular disease, risk of stroke and so forth. I would say we can distinguish a bit between the heart and the lungs. For the lungs, it's usually something where we are going more by symptoms. So if a patient develops cough, dyspnea, and so forth, that then leads to more testing, or if they have crackles on auscultation of their lungs, so when listening to them with a stethoscope. For cardiovascular disease, that seems to be universal, so that RA patients in general have a higher risk of cardiovascular disease, but there's also no specific screening test. What is definitely important is to address all cardiovascular risks, at least as aggressively as for the average patient, but ideally more so.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Upstate rheumatologist Dr. Christian Geier about rheumatoid arthritis. Do we know what causes RA?
So, no. The short answer is no. We do not know why it develops, but we know a lot of puzzle pieces about it. What we do know is it's a problem of the immune system. It is a problem with inflammation, and there's not a single reason. So genetics are very important, but when we look at, for example, identical twins, when one twin has RA, the risk for the second twin to develop RA is about 15%. That's much higher than on average, but 85% of identical twins will not develop it. So there are other reasons why people develop RA that are probably from the outside. A huge risk factor is smoking and also exposure to other inhalants. For example, coal mining historically was an issue. People that are exposed to pollutants and so forth develop it more. There seems to be also an association with certain periodontal diseases. So inflamed gums seem to be a risk factor, involvement of the microbiome and so forth. So it is clear that it's not one reason. It's really a combination of things that need to happen, and it happens over time. What we also know is that it takes usually many years for it to develop. There have been studies done collecting blood samples from young military recruits, and the military has monitored them longitudinally, so over a long time, until they develop a disease like RA. And when you go back to the people who develop RA many decades later and check their original blood samples, they often already had positive blood tests for RA antibodies. So it is usually something that really takes time to develop. There probably are a combination of important kind of checkpoints and hits that have to happen until the RA develops.
Is it true that many more women than men are affected by RA?
Yes, that's definitely true. That's the case for most autoimmune conditions. Problems with inflammation, women in general are more susceptible to autoimmunity, and that's also the case in RA.
Does that mean that hormones play a role?
Probably yes. With RA, generally it seems that high hormone levels are protective. So for a woman patient who has RA and becomes pregnant, for most of them, it improves during pregnancy. And if anything, then may flare up after childbirth. So it is probably not a problem with high hormones. But that's just not really entirely clear with women in general and the susceptibility to autoimmune problems. But that this perhaps that the fluctuation of hormones leads to kind of switching on and switching off of the immune system more frequently. That may play a role. But usually it is much less common in these kind of younger years, and it's less severe in high hormone states as opposed to other autoimmune conditions. For example, in lupus, a different autoimmune condition, it's almost the opposite. That is definitely a disease much more associated with high levels of estrogens, for example. So it is not known why women have more. The other thing is this 2X chromosomes, so that the X chromosome certainly has certain immune genes that women have then more of, that there may be some dose response of that. So it's not unique to RA.
Well, let's talk about how rheumatoid arthritis is managed or treated. First of all, what happens if it goes undiagnosed and untreated?
If it's untreated, it will lead to deformities of the joints. So over time, the chronic inflammation can lead to joint damage. And then that can also essentially destroy cartilage and then also other structures of the joints. So tendon, ligaments, and so forth. That's really the short-term thing. And then the second thing is also untreated inflammation, as I said, also has these cardiovascular risks that then can also be a problem. So it is definitely important to diagnose and treat RA early on.
Are you able to reverse or to at least halt joint damage with treatment?
Yes, the treatment really goes by disease activity, and the goal of treatment is usually to get disease activity into remission or low disease activity. What that means is that an RA patient in this category usually develops the same rate of joint damage that we all do. So that's just the normal baseline. So that essentially halts the joint damage, reversing function. So when a patient has had active RA and has lost a lot of grip strength and so forth, treating the inflammation will lead the patient to become much more mobile and they can regain a lot of strength. It's not that the damage itself can completely be reversed on an X-ray, but what can be reversed is the impairment from the RA. So they can use their joints oftentimes very close to before, even if there may have been joint damage radiographically.
That's good to know. There are medications that are used. How do those work?
On a larger level, they are anti-inflammatory medicines. So because the problem is overactivity of the immune system, these medicines, generally speaking, suppress the immune system to different degrees and in different ways. The goal is to treat excess inflammation and still leave the immune system alone so it can do its job. So protect us from infection, protect us from cancer, but just dampen everything so that this extreme inflammation that occurs in RA patients is controlled.
How important is exercise?
Exercise is extremely important. Once a patient is treated with medication and has control of inflammation, it's very important to regain function, to exercise. You can imagine it's almost like a person in space. When you have inflamed joints, you can't move them and the muscles will atrophy. So the muscles are not being used and the body breaks down the muscle tissue to fuel the inflammation, essentially. And stopping inflammation itself doesn't regain strength. What it does, it then allows to regain strength through exercise. So that is often a problem that even when the blood work looks fine and the inflammation on exam is gone, patients may still have pain and impairment from it. And that's really a good sign that really more exercise is needed. So to practice grip strength is extremely important. Mobility in general is extremely important. This kind of inflammatory pain, this inflammatory process really thrives on immobility, on staying in place. And often patients make this discovery themselves that movement and mobility and heat are all very useful.
So when we talk about exercise, is it strength training with weights or is it cardio stuff with walking or swimming or biking?
Ideally, both. One thing I like, and patients tell me they like, is, for example, aquatic therapy. So to be in warm water, that can alleviate a lot of joint problems by itself. And it also has some cardio exercise. It also allows to move joints without impact. So this is good. So cardio is also good for other reasons. I would say in the short run, if dexterity and hand symptoms are a problem, like dropping objects, or just having a lack of strength, then focusing on the hands can be good. And physical therapy and occupational therapy can be very, very useful.
Let's talk about diet. Are there any foods to avoid, or are there foods that you do want your patients to consume that would help with the inflammation?
In some cases, some patients with RA, there seems to be the possibility that it is triggered or made worse by certain foods. That is something that the patients themselves may discover, and that has definitely been described. It is not like there's a single food that causes RA and so forth, but what can be useful is like an elimination type of diet, kind of based on this kind of paleo diet. The idea is to really, in the first step, eliminate all modern and highly processed foods and then reintroduce them one by one. And that's something that patients who are interested can do themselves to detect maybe what kind of food may be playing a role in them. Usually a good side effect of that is also that patients tend to lose weight with this, because cutting out carbohydrates and all processed foods also often leads to weight loss, which is also a good side effect. There's not a single food, but it can be certain foods that may trigger it in some cases. Other popular nutritional things are turmeric, that has some followers, and then also things like fish oil. And these things don't have any dramatic effect, but they can be useful in some patients. So if patients want to try out additional supplemental therapies, that's something to try. And there's huge variability. For some patients, it works. For some patients, it doesn't. So I encourage people to try out what works for them.
So fish oil and turmeric you can get over the counter at a drugstore, but turmeric you could also use in cooking. It's a spice, right?
Yes.
Can you tell us what life is like for someone with RA? How might the disease impact their daily routine?
It varies a lot. So when the disease is controlled, it may not impact them at all. Before the diagnosis, or when there's issues with lack of medication access or other things that cause a flare-up, it can affect them a lot. As I said, the symptoms are really stiffness, pain, and inflammation of their joints that's most impactful. So it can be very difficult to get the joints moving. It can, in very extreme cases, make them dependent on a wheelchair. Fortunately, these cases are rare, but sometimes we see cases with problems seeing a rheumatologist in time, and people are either not diagnosed or not treated or undertreated. So it really varies. Other cases can be much milder, where people just happen to see us for a different reason, and we find they may have had RA, but they're asymptomatic. So it can be a wide variety.
Does this condition reduce a person's lifespan typically?
What is definitely an issue would be the increased risk in cardiovascular disease. So generally not, but it can in some patients. One of the potential complications is lung disease. It's a rare complication, but if it develops, it can be quite severe. And then it reduces their lifespan a lot. So it usually would reduce their lifespan to a median of about 5 years or so. Again, it's a very rare complication, but it can happen. So for those patients, yes. For the vast majority of RA patients, the effect is much less. And if there is some reduction in lifespan, it's through cardiovascular disease. Cardiovascular disease is a big problem in general, like heart attacks or stroke or other cardiac issues. But with RA, there seems to be a higher risk. The classic teaching for that is that a patient with RA has the cardiovascular risk of a non-RA patient that is 10 years older. So it is certainly important for these patients to take good care of their heart and their blood vessels, which again goes to making sure, ideally, if they are smokers, to quit smoking, making sure that their cholesterol level is controlled, that the blood pressure is controlled, and that they really follow other recommendations for heart health in general.
Once a patient has been diagnosed, how often do they come to see a rheumatologist?
So in the best case, where a patient is completely fine and is tolerating the medications well and everything is stable, usually every 3 months. So it would be 4 times a year. For patients who have a lot of difficulty, some of these visits can be done through telemedicine visits if they're from far away and they're completely well controlled. That's usually the purpose of these visits, to make sure that the patient is feeling well, that their joints are not inflamed, that they're tolerating the medications well, that they also typically get screening blood work to make sure that liver, kidney, and blood counts are all where they should be. And it's also a good opportunity for preventative care. Another thing is that their vaccinations are up to date, especially for the winter months. Anybody who is on medicines against inflammation always has a bit higher risk of infection. So it is recommended to have, for example, pneumonia vaccines and so forth. And then, of course, patients with RA have all the same health needs that also the non-RA patients may have, and that's another aspect.
Would some of them who maybe are at risk for the cardiovascular or the lung issues, would they also see a cardiologist maybe or a pulmonologist?
Yes, definitely. For the lung disease, we have a specialized clinic that we work with. For just the risk of heart disease, it is not necessary to see a cardiologist. But if they've had cardiac events, for example, if they have had a heart attack, for sure, then it's very important to follow closely also with a cardiologist. That's right.
What is the overall outlook today for someone who is newly diagnosed with RA?
It's generally very good. There's good things. So one is that medicines usually work very well, and there's also many medicines to choose from. So even if one type of medication doesn't work for a patient, there's a lot of classes. It's actually one of the areas where there has been a lot of interest by the pharmaceutical industry to develop new medicines because they have been very profitable. But that really does benefit patients because there's a wide selection to choose from. So if a medicine doesn't work, others are available. The big thing really with RA is, on one hand, our job. So we really need to explain to the patients why it's important to take these medicines and to be open with it so they trust us and they take their medication and follow up. And then it's usually not a huge medication challenge to do it. It's really about convincing patients that we can help them and that these medicines are working.
Well, Dr. Geier, I want to thank you so much for making time to talk with us about rheumatoid arthritis.
Thank you. Thank you very much.
My guest has been Upstate rheumatologist Dr. Christian Geier. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.